Without further ado, I think we should get started, and I will introduce the first speaker, Dr. Malay Sharma, who's already up on stage. Dr. Malay Sharma is from Meerut in India. He is an expert on all things EUS. He's written a textbook on EUS anatomy, I remember that, which is amazingly detailed, and he's really the right person to do this talk on mediastinal oncology, I guess, as it applies to EUS, right? So over to you, Malay.
And I think if there's anyone on the virtual platform, you can ask questions through the app.
Yeah, and I think we were talking also about taking questions right at the end, right?
Yeah.
So after all the speakers have done their talks.
So mediastinal oncology, what are we worried about? We want to know about esophagus, lung and pleura. For example, this is a case where we see a cyst on endoscopic ultrasound. Below is the gyrgos vein, above is the brachiocephalic vein, and this is the pleura. And we get a CT, this is what it is. This is a bronchogenic cyst. So this bronchogenic cyst is affecting the trachea, requires more of a surgical excision. So we have to understand the concept of compartment. When we are talking of mediastinum, where is the disease present, in which compartment? There are three: neck, thoracic cavity and abdomen. And within the thoracic cavity, there is a central and a peripheral compartment of the cavity. So a central disease is spreading to peripheral, or a peripheral disease is spreading to central, is change of compartment, and that is what we want to know, whether there is a change of compartment so far as disease is concerned. And broadly, if there is a lung disease coming to central compartment, it is inoperable, or any compartment change makes the disease inoperable. That is the principle, and that is why the concept of compartment is important before we embark on to understand what is the mediastinal EUS and how do we do EUS and also endobronchial ultrasound in a staging of lung cancer, which is our primary aim. And the first step is second step is diagnosis, getting a tissue diagnosis. The question is, where do we get the tissue diagnosis from? If bronchoscopy is negative, that is the question, and then that is where we have to do either EUS or endobronchial ultrasound or transthoracic FNAC or whatever. For example, this is a mass, case 1, T3 and T0, and this is case 2, and we have to find out how we can get into this mass, whether we can get close by endobronchial ultrasound or EBUS. So example, so then the fifth step comes is T and N and M staging in a lung cancer. We want to know more about the tumor, more about the nodes, and more about the metastasis. Like this is a tumor lying at the upper border of the arch of aorta, for which this is a tying lateral to the arch of aorta, and we can see, but it is difficult to take FNAC. And in this case, we are going to go through the aorta to take an FNAC of this mass and able to evaluate. So when there is an indication, there is no contraindication, and you have to do these FNAC. This is again an EUS and endobronchial ultrasound image. The tumor is beyond the aorta, and it is difficult to get FNAC, but through subaortic route or through supraaortic route or through transaortic route, you can take an FNAC. So one of the things is, if you cannot do mediastinal tumor staging from EUS, you can try by EBUS. And so coming to T4 staging, this is most important indication why you are doing EUS of mediastinum, because mediastinal invasion is the most important thing. It is the indication of endoscopic ultrasound, and these are the aorta, superior inferior vena cava, pulmonary trunk, veins, chambers of aorta, gyrgos vein, and the pleura. That is what you are evaluating. For example, this is a case where there is a mass, lateral to the mass, there is mass. This is the plane between the aorta and chin. There is no invasion of aorta in this case. But here in this case, there is invasion of all the round. The aorta is encased, the superior, the common carotid artery coming out from the aorta is encased by the tumor. So the T staging, this becomes T4, and then that is where the tumor is invading into the lung, and it is invading into the lung, it is going into the superior vena cava, and then comes the nodal staging. As I said, the first is endoscopic ultrasound, most important for tumor invasion staging, and then for T staging you evaluate by B mode, color mode, elastography, contrast study of the node, and then we have to decide which are the nodes present. This is the nodes which you can see. The green color is all which are accessible only by endobronchial ultrasound, blue by endoscopic ultrasound, and the red both. The question is, if you are really persistent, all these green color nodes, many of them can be assessed by endoscopic ultrasound, and we keep on trying. And as I said, it is possible to take FNAC of these nodes even by endobronchial ultrasound. This is a case with adrenal mass, and then with adrenal mass, this is a case, and then in this case there is left adrenal mass, and when you see this is left adrenal mass, when you pull back a little bit higher up, in this same case you will find that there is a lung mass, and this lung mass is lateral to the arch of aorta, and this is a lung mass with adrenal metastasis. So then we have M1B, M1C staging of the lung cancer. We can do staging of the lung cancer. And the question is, which node should be biopsied first? When you are doing an EUS of mediastinal node in a case of lung cancer, contralateral node should be biopsied first. Otherwise, you will spread the lesion to the other node. And this is the order of a M1B, N3, N2, N1 if you want to do FNAC of the lung mass, lung nodes. Staging of lung cancer is also possible because this is pleura. As I said, pleura is involved. There are 3 pleura, mediastinal pleura. This white line is the pleural line, and this white line has got lung rockets. And then this is a supraortic mass. This is mass just above the arch of aorta. There is fluid, and you can through this fluid go into the mass and do FNAC of the mass. This is a supradiaphragmatic mass, and this is a mass again involving through the mediastinal diaphragmatic aspect of pleura, which you can find. So pleura is very easily accessible. The 3 aspects of pleura and the pleural deposits can be biopsied. So this table broadly summarizes, looks too good, but too big, too cumbersome, but first step is X-ray, CT scan. Second step is select options of biopsy. Third step is select what is the tissue diagnosis. How will you get the tissue diagnosis? Then if you are going to do a surgery, and then you have to do linear or endobronchial ultrasound in a case of lung cancer to evaluate. What about esophageal cancer? When you look at esophageal cancer, the first thing we have to find out is that if there is an epicenter less than 2 centimeter or more than 2 centimeter, this is CO esophagus versus CA stomach, and this is the CA. The epicenter is in the stomach in this case, so this is an stomach cancer, whereas this is esophageal cancer, we have to remember the particular lymphatic drainage pattern. Whatever tissue you want to evaluate, you have to understand the lymphatic drainage of that tissue, esophagus, stomach, pancreas, gallbladder, rectum. Unless you know the lymphatic drainage pattern, you cannot evaluate, because the lymphatic drain, they go out, they keep on going out to the submucosa, and then they go into the periesophageal duct, and then they will go into the thoracic duct, which has got wall, and that is how it travels cranially. So this is, but the problem is in the submucosa, it goes up and down, it goes cranially up and down, and it has got a lateral spread, longitudinal spread, when it spreads into the submucosa both up and down, and these are the tumor cells migrating up and down into the. So this is important because esophagus, the longitudinal spread is responsible for the tumor spread, and that is why when you get these paraesophageal nodes, the current trend today is to remove the paraesophageal node, and the longitudinal spread does not necessarily mean that the esophageal lymph node, which is lower down, can be resectable. So it is not the adjacent lymph node which is important, and if there is a tumor lymph node lower down, you can probably remove it along with it. But broadly, the upflow is much more than the downflow. That is what you have to remember. But there is a contralateral flow, opposite side flow, especially from the left lung going to the right side. This is an example. There is a lymph node. This is the azygos vein. This is the joining of superior vena cava. This is a 4R lymph node, and this 4R lymph node is easily accessible by endoscopic ultrasound. As I said, with persistence, you can really find out and evaluate what is the node, and that is how we start doing esophageal staging of the lymph node staging, with the T and M staging in a case of esophageal cancer, and this T and M staging is as outlined below. The only thing is this is a cancer, esophageal cancer. There is thickening of the layer number 2, layer number 3, and once you start thickening of the layer number 3, sometimes the biopsy may be negative, and when the biopsy is negative, you are looking for the thickened wall in the esophagus, and you can be doing a tangential biopsy sometimes in these cases. So when we do endoscopic ultrasound, the sensitivity, specificity is low, but the high frequency of any imaging is low. Only available imaging is endoscopic ultrasound, and high frequency endoscopic ultrasound probes are used for the early esophageal cancer, and that is what we get when you get early esophageal cancer staging. And this is the line. We use thin probe or mini probe for evaluation of early esophageal cancer. However, when it comes to T2 staging, this is high, but overstaging may occur, and this is the classical example of this tumor is the esophageal wall. You can see this is the thickened mucosa, submucosa, and just above the muscularis mucosa, you can see the thickening. As I said, this is the lesion, and in which this is a esophageal lesion, and in this esophageal lesion, you can do FNAC by tangential match, which you have to sometimes do if the biopsy is negative. When it comes to T3 stages of esophageal cancers, higher sensitivity, lower specificity, and when it comes to, this is an example where there is a T3 tumor, but you can see the movement of pleura is outside, freely moving pleura, and the azygos vein and the azygos vein on the other side along with the spine, so there is no extension. In T4, again, as I said, esophageal cancer for mediastinal invasion, it is the most sensitive test if it is non-traversable tumor and the accuracy of the tumor is very high. And this is. But as I said, when it is esophageal cancer, there can be invasion of the other lesion, there can be mass invasion into the left atrium, and these invasions can be, and this is case where there is invasion into the bronchus, because this is the characteristic feature of the bronchus. Air within the bronchus is seen, and you can see. So the N staging of cancer as in classification is 1 to 2 node, 3 to 6 nodes, and 7 nodes. This is the way you classify. And the esophageal cancer staging, again, as I said, T, N, and M staging has to be done esophageal cancer. People really usually do not work so hard in T and M staging of esophageal cancer, but I believe it is worth it, because as a gastroenterologist and as a sonographer, every tumor must be having endoscopic ultrasound is a must for every esophageal cancer tumor. And this is when you do ISGE classification, this generally applies for lung cancer, but for esophageal cancer, the nodes are sometimes described in the same station that we do generally describe for the. So these are the different stations that have been applied. I will not go into detail as to how to see these stations, but this is just highlight that these are the subcarinal area, or these are the different areas that we see. So then you can sometimes be able to do FNAC from higher up. These are the supraclavicular lymph nodes FNAC, and then this is the tumor, which is a very small node, and in this case the lymph node, the esophageal wall is thick, so this is lymph node, you cannot really traverse through the wall of the esophagus, so you have to, because you, in this case, if you want to do FNAC of this node, and the surgeon or the patient who is evaluating this node, this is a PET positive node, you have to go outside, you have to do the other route. So never traverse through the tumor, choose the other route for the tumor. Here this is the peritumoral lymph node, and then this is a peritumoral lymph node, and then this is a lymph node just above the arch of aorta. And so there are different nodes. So the scope selection is different. When you are talking of esophageal cancer, you can use slim scopes. Slimmer scopes are now available both by the Olympus people as well as by the Pentax people. The slimmer scope is available to traverse through the esophagus, but if you cannot really traverse, use the EBUS scope to travel down, and you can evaluate esophageal cancer very well by the EBUS scope. So the final comments I would say, so each modality complements in the staging of malignancy, and the accuracy of EUS depends on the location of tumor. A multimodality approach should be used to stage a mediastinal malignancy, and we should be looking to do FNAC wherever it is possible by mediastinal endoscopic ultrasound. EUS is an excellent tool in locoregional staging, can add information beyond CT, and we can take somebody off the table. Unnecessary surgery can be avoided, and I would go on to say surgery cannot be done without EUS. Nodal counting is needed if you are doing node. How many nodes? Where are the nodes? Chest has problems in nodal counting because chest has many lymph nodes are normal, and especially subcarinal area, and in the right paratracheal area, even large side lymph nodes may be. So you have to really characterize the lymph node size, shape, and character, which you can do by endoscopic ultrasound and assess whether the lymph node. The nodal sampling may be needed, and this is interesting that the route of sampling sometimes in esophagus, in esophageal cancer can be through bronchus, and sometimes in the lung cancer is quite often through the esophagus. So thank you very much. This is all I have to say. So unfortunately, I will have to leave because I have a flight to catch. So I will apologize if there are any questions. I will answer right now.
Yeah, so I guess we should take questions for Dr. Malay Sharma now. Any questions from the floor?
I have a question, Prof. Now the emerging endoscopic therapies for the malignancies, our pulmonology colleagues, they're doing the APC endoluminal for the lung cancer. So maybe in future, can we combine we have the RFA now, EUS guided. So EUS therapy combined with the endoluminal therapy, could this be the way forward for CA lung or mediastinum?
Means it is already emerging, I think, in gastroenterology for pancreas and for liver, it is already emerging. I don't know for what sort of lung tumor it will emerge. Esophageal, less likely.
Lymph nodes can be accessed via EUS? Transesophageal route lymph nodes in the mediastinum. So can we RFA or is the
lymph node RFA? I am not so sure, but if there is a PET positive single lymph node, RFA of lymph node, has it been practiced, and is it a practice for other cancers? If it is a practice, solitary lymph node metastasis, RFA may not be a bad idea for inoperable case. Yes.
Every now and then our radiation oncologists, if there's one node they want to target, we have put fiducial markers in them as well.
Yeah, Malay, thank you for that terrific talk. You mentioned in one of your last few slides that we shouldn't be doing lung cancer treatment without EUS. But nowadays everybody gets a PET CT. How does that square up with PET CT being done for all our patients? Do we still really need EUS for all these patients?
See, I imagine a scenario in a tumor board meeting where a lung cancer has been operated. CT scan, myself, PET CT, surgeon, and guns. Whosoever is correct, and I will win the most rounds. I'm very sure. So the reason I'm saying PET CT can have so many false images, and today is the era of multimodality imaging. Yeah. So when you are doing multimodality imaging in algorithm today, PET CTs, almost every cancer you are doing PET. So almost every cancer, why you are not doing EUS? The only reason you are not doing EUS is because the lung people are not allowing you to get in. How can they not have a EUS for mediastinal lymph node? There is 3.5 centimeter they can be size. So CT is picking up only a large 3.5 centimeter node, but a sub-centimeter node which cannot be picked up by best of the CT will be rounded node, will be picked up by me, will be picked up by us, will be picked up by US. So I am very clear, you are adding on by all imaging. So you cannot do EUS and cannot do any surgery, whatever it may be. Even gastric cancer, it has not been included. Gastric cancer, but I say you cannot do any surgery without doing an endoscopic ultrasound. It is a passionate statement, but maybe tomorrow it will be proved true.
Just a small question about the role of antibiotics. Mediastinum is a closed space and the guidelines don't recommend. But do you think that it's mediastinum is a closed space and there is a role of some prophylactic antibiotics? Or have you encountered any infection during biopsy?
Hardly. I don't know. I mean, it has not happened. If it happens, we will know. No problem.
I know we're over time, but one question.
Yeah.
Our oncologists still have us do EUS staging for esophageal cancer after neoadjuvant therapy, but we know it's not as accurate. So in your center, are you doing it still?
We are doing it. The problem is we don't have so many post-op. But you should keep on doing it, because if we don't do, how will we find what role we have? So this is very important. We must be everywhere. We could keep on butting our head in everywhere.
I like it. All right. Thank you very much for that nice lecture and very passionate advocacy of EUS. But thank you.
Thank you.
Thank you, Prof.
Yeah.
All
Safe
right.
travel, Malik.
Yes. Our next speaker is Dr. Tawfiq Kachami. He is the Chief of Medicine and Director of GI at City of Hope in Phoenix. And his interests are in endoscopic oncology, including ablation, which he's going to talk about now.
Thank you very much for the organizers for this invitation. It's an honor to speak to you and the group. So I will be giving some tips on performing cancer ablation. And I always like to start by saying that cancer ablation is a discipline, is not a procedure. So a lot of what I will be talking about is how to really develop that discipline. And a lot of it has to do more than with technical aspects of ablation. These are my disclosures. And ablation is from the Latin term to remove or carry away. There are many forms of ablation. Medical ablation is the removal of a body part or the destruction of its function. In its general form, almost everything we do for cancer is ablation. Surgery and chemotherapy is chemical ablation. And endoscopically, we use often technologies related to either heat or freezing or electrical, and I'll be mentioning some of these. So my objectives today is to provide an introduction to endoscopic cancer ablation, talk about the role of the endoscopist, discuss the cognitive knowledge needed to embark on cancer ablation, how to approach the multidisciplinary team, and the approach needed to care for cancer patients. And I will end by highlighting two modalities that I believe are ready for prime time for endoscopists who want to embark on this discipline. The first thing is to stress is the importance of a team approach to cancer care. I always think of the medical oncologist as the quarterback and the surgical oncologist and the radiation oncologist as a part of the team member, and more recently the gastroenterologist, or what I like to call the endoscopic oncologist, is another team member. And there are others involved often in the care of cancer patients, like nutritionists, physical therapists, social workers, and psychologists. But increasingly, a gastroenterologist is becoming a full-time employee in cancer centers, like I am, where I've been for the last 14 years. What impacts the tumor response to ablation or even to systemic therapy? There are multiple things that impact that. One is genomic diversity. And what do I mean by genomic diversity? When you look at the diversity between the tumor itself in the GI tract, the lymph node metastases, and the distant metastases, you find that the tumor itself is the most diverse. As the tumor moves to the lymph node, it becomes less diverse genomically, and then as it moves to the metastases, then it is a little more uniform. Why that's important? Because the response to systemic therapy is different in all of these, and this is why in most cancers, GI cancers, what you see is the fact that we have to use local therapies and systemic therapy, and that's what we call multimodality treatment, because the tumor itself sometimes is less responsive to systemic therapy than the rest of it. And this is where cancer ablation is becoming part of the multimodality treatment. So it's part of the group of local therapy. So the tip number one that I want to talk about is learn oncology. When we are going to provide cancer care and we're going to be a part of the multidisciplinary team, we need to speak the same language and understand what the oncologists are talking. So terms like complete clinical response, near complete response, no evidence of disease, progression-free survival, and et cetera, et cetera. We need to be able to understand what they mean by when they talk about that, and we need to be able to talk the same language so they see us not as a gastroenterologist, but as an endoscopic oncologist. So learning oncology also requires learning data on disciplines outside of our discipline. So when you want to stage cancer, for example, you have to know how the oncologists stage cancer and how the surgeons treat cancer, and what do their modalities benefit and where is the harm, and how does the modality that you will be using for cancer ablation be better or worse than their modalities, and this is how you can offer it. Obviously, you want to offer the modalities that are better with less side effects. One of the benefits that we have as gastroenterologists is access to the GI tumor itself, and often our modalities, cancer ablation included, are safer because we are not traversing other tissues. For example, when people are treating pancreas percutaneously, they have to go through the liver or they have to go through other organs, which increase the adverse events of their modalities, versus the same modality developed endoscopically is typically safer, and that has been shown through different modalities. And last but not least, the NCCN guidelines is kind of the Bible for cancer care, and it's important for someone embarking on this discipline to be familiar and understand the NCCN guidelines and understand how the guidelines are developed and what's in the guidelines. So this way, when you're providing the therapy, you are able to explain where it fits within the guidelines. The second tip is multidisciplinary engagement, and I kind of touched a little bit on that. Specifically, I recommend for anyone who wants to perform cancer ablation to go to tumor boards, attend tumor boards, discuss with the multidisciplinary team what they can offer, and to identify the ideal patient for endoscopic ablation as a team. You don't want to offer a modality where after you do the procedure, especially if the patient doesn't have a good outcome, where you have finger pointing among the team. That's not only confusing to the patient, it will kill your practice very quickly. So be patient, talk with the multidisciplinary team, explain to them the modality that you're using, have their buy-in, and if they're not buying in and you can't convince them that maybe this modality should not be offered at your center. Tip number 3 is building rapport with patients and caregiver. With cancer care, unlike with episodic, for example, colorectal cancer screening, it's a long-term relationship with the patient, and cancer patients are under a lot of stress. Chemotherapy impacts their cognitive abilities as well. So your caregiver is often the caregiver of the patient is often your ally in making sure the patient is following your instructions, holding anticoagulation when these need to be held. Something as simple as that you could potentially take it for granted, and patients are not undergoing cancer therapy. You have to go the extra step to make sure that happens, because there are so many procedures and so many appointments these patients have, and it can get very confusing. Also, building rapport with the patient is very important, as some of the modalities you will be providing could become the only modalities of treatment for the patient, and you might find yourself as the main physician for the patients. So I've become personally very familiar with goals of care conversation, end of life care, the hospice agencies that are around us, and how to connect the patient with them, because when you are taking care of the patient, and especially if you're the only one, then when the time needs for a patient transitioning to less aggressive care, you need to be able to help them and not say good luck to you. Okay. Tip number 4, think like an oncologist. And what do I mean by that? You have to provide the patient with a treatment plan. What's a treatment plan? Is what do you expect in terms of scheduling the procedure, pre-schedule all your procedure. For example, when patients come to me for cryotherapy at the beginning of their diagnosis, I pre-schedule 4 procedures. We time them with their chemotherapy, and we provide that as a treatment plan for the patients. Oncologists are very familiar with that. Gastroenterologists tend to try to throw in the patient on last minute, and that doesn't work in a patient who has a complex schedule where your procedures could impact chemotherapy, could impact infusions, or could impact other appointments. The other thing that's important to think as an oncologist is the assessment of treatment response. Gastroenterologists are very familiar with protocols. They say, I want to do this and that for the patient. But in reality, if what you're doing is not working, you either have to change what you're doing, or if what you're doing is causing side effects, then maybe you have to lower your dose. So in my practice, I don't follow rigid protocols. I adapt to the response, and I change my treatment based on the efficacy. For example, if I'm doing cryotherapy, which is something that I'm going to show you in a little bit, and I'm using 3 times 30 for treatment dose, and the patient is not responding the way I anticipate, then I will up my dose. I'll either do 3 times 45 seconds of freeze, or I will bring the patient every 2 weeks instead of every 4 weeks, for example. And then it's very important to talk about the goals of your therapy, and be familiar with palliative therapy, curative therapy, and in the world of cancer ablation, we typically are either palliating or are trying to eradicate disease. So we're either in the palliative realm or in the curative realm. And in the past, the word curative was a taboo in cancer care, but more recently, not only it has become accepted, it has become kind of the goal for many patients that we did not think were curable in the past. So often the therapy that you are providing with ablation are part of multi-modality treatment. And I'll give you a couple examples of curative and palliative, but it's very important, especially that there has to be no confusion for the team as what you are trying to do. So if you're trying to palliate the patient, that should be very well documented in your chart. I have the discussion with both the patient and the caregiver as what we're trying to do. One thing that we are increasingly trying to go after, which has been the holy grail for endoscopic ablation, is the abscopal effect, which is a systemic response to a local therapy. And more recently, we have modalities that are starting to be effective in that, and that's something I think you should keep an eye on. Here's a procedure with the intent was curative treatment. This is a patient who refused surgery, who had total neoadjuvant therapy for rectal cancer, and after a year he had recurrence locally, so we did cryoablation on him. It's been 2 years now with no evidence of cancer, and the goals in this situation, because the patient was not symptomatic, was to get rid of his cancer. Here's a palliative treatment. This is a patient with esophageal cancer, who you can see on the left, her esophagus was completely obstructed, and after 3 treatments she felt significantly better and her swallowing was better. So we were just trying to improve her symptoms, palliative care, and this happened despite progression of disease. You see on the PET before and after treatment in the esophagus, the activity was significantly less because we were tackling the esophageal part of her tumor, versus in the stomach her activity was significantly stronger on the right compared to the left, which is after treatment. So this patient was getting symptomatic improvement despite progression of disease. I classify ablations into luminal versus transluminal, so whether they are delivered on the mucosal side of the disease or transluminally via endoscopic ultrasound. I also divide them into different modalities based on the energy delivered: radiofrequency ablation, cryotherapy, pulse electrical field, microwave, etc. And then whether they are fixed versus adjustable. The fixed dose therapy are therapies where you just press on a pedal and a delivery of treatment occurs. As a therapeutic endoscopist taking care of cancer patients, I like the adjustable ones, and I told you why, because I like to tailor the therapy to the response. And then tip number 5 is monitoring of disease. When you in many of the guidelines, for example, the case that I'm showing, the guidelines don't always recommend that you scope the patient after treatment. This is a patient who had a stage 3 GE junction cancer, had chemoradiation, had a complete clinical response like you see in image C. And if you read the NCCN guidelines today, they do not recommend treatment. But if you have therapies to offer in case there is recurrence, then I scope the patient. This patient declined surgery initially, and so when we followed him with serial endoscopies, there was recurrence that you see on image D, and this happened 9 months after he had a complete clinical response. We offered him cryotherapy, and then he went into remission. You see after cryotherapy on image F how his esophagus looked, and then he, after surveillance for 3 years, he recurred. And the second time he recurred, he actually accepted surgery, so he went for surgery. If we were not monitoring this patient carefully, we would have missed this opportunity. Okay, so I was going to give 2 examples of luminal and US guided therapies. So liquid nitrogen spray cryotherapy for esophageal cancer, we did the research on it, has been shown to, in addition to systemic therapy, to improve dysphagia and improve quality of life. And as part of the ASGE special interest group, we prepared a video on how to do it. It is available in GI Leap. I would encourage you to go and see the details of how it's done. Another therapy that I think is ready for prime time is USRFA for pancreatic neuroendocrine tumors. The previous speaker talked about a little bit USRFA, but we have a meta-analysis on around 200 patients. Where the clinical efficacy, either if it's a secreting tumor, the secretion went away, or if it's a visible tumor, the tumor disappeared in 95% of the cases. And severe adverse events happened in 1 of the 183 patients. So I think this is a therapy that could be adopted today, just like the previous therapy that I discussed. Typically, what we do is put the needle in the tumor and then we ablate. This is an adjustable modality until the hyperechoic changes get to the edge of the tumor, and then we move the needle until the entire tissue becomes hyperechoic. So in summary, endoscopic cancer ablation is a discipline and not a procedure. The requirements are acquiring oncologic expertise, adopting new technology, working in a multidisciplinary team, defining the goals of care, and having rigorous surveillance protocols. Thank you very much.
You want to ask a question? I think that I think that since we have 2 speakers now that are on site, so I think we're going to do Q&A after each talk. Yeah, sorry about that. Yeah.
I would love to take any questions.
Yeah. If anyone in the audience want to ask a question, please come to the mic. But I'm going to start off with you mentioned about the RFA and PNET. It seems like we do have some data, and now the interest is kind of leaning towards the RFA in pancreatic ductal adenocarcinoma as well. I think the data is emerging. Can you comment a little bit on
there's
that?
significantly less data on pancreatic ductal adenocarcinoma. The fact that it has such a poor prognosis, it is reasonable to do. We do offer it as long as it's done in a multidisciplinary fashion. There are 2 reasons, in my opinion, to do it in the locally advanced, where you are trying to convert the patient, or if you're looking for an abscopal effect. There's currently a randomized controlled trial being led by Nirav Thosani on small doses of ablation repeatedly done in an attempt to induce an abscopal effect. I think potentially in addition to immunotherapy that might happen, but we are all anxiously awaiting the results of that randomized controlled trial. But I think as long as it's offered in a multidisciplinary fashion, it is reasonable. There isn't data showing that it's helpful.
Okay. In your practice, how do you select the patients?
As a multidisciplinary team. So if you have let's say a young patient who is otherwise healthy, has failed a couple lines of chemotherapy, and then they're trying to offer something more, and there's no clinical trial, and that's something we could offer for the patient. It has to be very specific. It has to be everyone is buying into it. Yeah.
And in your practice for the PNETs, you're just treating the symptomatic ones?
So it's
in our hospital, we have a very aggressive surgeon who likes to enucleate a lot too.
Yes. Yeah.
So we are only treating symptomatic insulinomas for the most part.
Yeah. So the PNETs, with the treatment algorithm kind of depends on the size, whether they're less than 1 centimeter, between 1 and 2, and more than 2. The between 1 and 2 are the most controversial. These tend to be the ones that, depends on the patient's functional status. Are they young? Are they old? Where is the location? So as long as it's done as a multidisciplinary team, we are offering it, but it's not something we're offering instead of, it's something we're offering with the surgeons. Is that consistent with your practice?
No, same. But the surgeons seem to capture the patient first, and then
Yeah.
they'll lean it a little bit
Yeah.
more towards them.
Yeah,
But
often
then I'll
it's the
put a
patient
PD
that the
stent
surgeon
in for
does
the
not
leak anyway.
want. Yeah.
Oh yeah.
Yeah.
Oh, see, yeah.
I
It's
think
often
that's
the patient- yeah.
similar around the world. Like I'm from Thailand, and that's how they work too. Because
Yeah.
patients go to the surgeons first,
Yep.
Yeah.
and they like to do a lot of enucleation. Yeah.
Yeah, and if they do a lot and they're excellent at it, I think that's great. With that said, if the patient is 80 and they don't want to do that, and they're concerned, the tumor has grown by half a centimeter this year, then this is typically they're asking us to do it. Yeah.
We've also been doing it for renal metastases, ablation in the pancreas.
Yes, renal tends to respond so well to
Yeah,
immunotherapy.
yeah. That too, but
Our surgeons love to remove the renal, so they're
interesting.
often removing these ones. Yeah, but they also respond so well to immunotherapy.
True.
Often they're ones who they get immunotherapy and they're responding very well. And for some reason, renal, like melanoma, they're very responsive to immunotherapy.
A quick question, Prof. A great talk. Hypothetical question regarding when we do biopsy, there is always concern of seeding of the tumor cells.
Yeah.
So during RFA, the track on coming back, can we do the thermal therapy on coming back to prevent that? Is it a hypothetical?
Yeah, it's an excellent question. In hepatocellular carcinoma, for example, or cholangiocarcinoma, that's a significant concern. In pancreatic neuroendocrine, it is not a concern. So we typically don't do that. We actually avoid treating the tract where there's pancreas, because then the risk of pancreatitis becomes higher. But this phenomenon of seeding is really very tumor dependent. From what we've learned, some tumors are notorious for it, like cholangio and HCC. And some tumors, we've studied it doesn't look to happen. When I started my practice, there was a huge concern about seeding ENT cancer on the skin when you place a feeding tube. I've been placing feeding tubes for the last 14 years. I've never seen it. And I looked for it all the time. So I don't think that phenomenon is anything more than rare. Yeah. In certain cancers. Yeah.
Okay, great.
Yeah. Excellent question. Yeah.
Okay, I think that's pretty much.
Thank you.
Yeah, thank you so much.
Thank
Yeah.
you.
So I have the pleasure of introducing our next speaker, Dr. Adrian Savtu. Dr. Savtu is the Chief of Gastro and Hepatology at the Ilias Emergency University and the Carol Davila University of Medicine and Pharmacy in Bucharest, Romania, and his area of expertise is diagnostic and interventional EUS. And today he will be speaking on tumor staging and three-dimensional imaging reconstruction techniques.
Thank you very much for the kind introduction, and thank you very much for inviting me to present this talk. So basically, I will speak a bit about staging and also 3D reconstructions. So these are my conflicts of interest, and I will start the talk by looking a bit at the NCCN guidelines for pancreatic adenocarcinoma. So basically what it's done in most of the centers, so there is a clinical suspicion of PDAC, and then the patients go usually to pancreatic protocol CT. And then after this, usually endoscopic ultrasound is the next step. So endoscopic ultrasound is, in most of the centers, is complementary. It's not replacing cross-sectional imaging like CT and MR, but it's a complementary modality which is used mainly for diagnosis, but also for staging. So you can get information about the resectability, also about the lymph nodes, sometimes about distant metastases, but mainly you can look very well at the vessels. So briefly, if you look at resectable disease, then you still need US guided biopsy. If you look at borderline resectable, you also need US guided biopsy. If it's negative, you have to repeat that. And you also get, after diagnosis, you get information about a staging. And it's the same thing in locally advanced disease. Again, you need biopsy before chemoradiotherapy. And if you look at diagnosis, we now have very nice FNB needles, which have a higher yield for histology. Usually it's over 90-95% in most of the centers. If you use third generation needles, then you will get higher yield of histology. And we know already that US FNB has an excellent accuracy for both the differential diagnosis, but also for staging, and that includes small tumors. And this is valid also for pancreatic neuroendocrine tumors, and this is one of our first examinations with contrast. We were using power Doppler, and you see that it's a very nice neuroendocrine tumor. There is a bit of vascularity before contrast, but after contrast, if you use power Doppler, you see that this lesion was hypervascular. And the advantage of US is that you can observe very small, tiny lesions. So this was a 2 centimeter gastrinoma, which was missed actually by CT and MR. And the patient beside this lesion had a lot of metastatic lesions in the pancreas. We counted at least 10. And you can actually target this kind of small lesions by US FNB, even 3 millimeter to 3 millimeter lesions. Then sometimes other masses are pancreatic metastatic lesions. So you need to do US guided FNB. You need to do immunohistochemistry to establish the diagnosis. However, the diagnosis is not obtained in 100% of cases. So that's why a lot of adjunct technologies were introduced, like elastography, which is a technique which works in real time, and you can easily see the difference in between the normal pancreas and the chronic pancreatitis, and also pancreatic adenocarcinoma. So there is a difference, and if you also are looking to meta-analysis, then you'll see that the elastography has a high sensitivity but a very low specificity. So the advantage of elastography might still be in small pancreatic lesions, less than 15 millimeters, because in those lesions, the negative predictive value of elastography is very high. So you can basically exclude pancreatic adenocarcinoma if you have a soft lesion like this one. So this is an example of an insulinoma, which is really soft. This is an example of pancreatic ductal adenocarcinoma, which is really hard on elastography. Then we looked a bit during the years on contrast enhancement. So contrast enhancement is a nice technique because you get rid of the grayscale information and you get only the vascular information. So we use microbubble ultrasound contrast agent, which is injected through an antecubital vein, and basically what you see on screen is only vessels. So we use this kind of split images. So on the right side is the grayscale image, and on the left side is the contrast enhanced image. And this is an example of a hypovascular tumor, a pancreatic adenocarcinoma. There are some tiny signals inside, so there are some tiny vessels inside, but not much. So this is an example of a hypo-enhanced lesion. But if you look at the resolution, it's very nice. You see the splenic artery here, and you see a rim of tumor tissue on the other side of the artery. So this was actually a complete encasement. So you can use contrast during vascular examinations to better delineate the relationship in between the tumor and the vessels. And I will come back to this a bit later on. You can see just a few examples of contrast. So some of the tumors are this is an example of a hypovascular tumor. So most of the solid masses, we know they are hypoechoic on grayscale, but some are hypovascular, like pancreatic adenocarcinoma. In metastatic lesions like this one, this was a metastatic lesion in the ampulla from a clear renal cell carcinoma, and you will see that it is hyper enhanced as compared to the surrounding pancreatic parenchyma. And this is especially valid for insulinomas. So for small insulinomas, they are hyper enhanced, and you can see this one, and you will nicely see that it uptakes contrast in the arterial phase. So there is enhancement here, but it washes out pretty fast. And you can see the relationship with the vessel here. This tumor was nearby the inferior venal cava. So this is important for staging and for therapy in some of the lesions. So you very nicely depict the vessels when using contrast enhancement. If you look at the data for diagnosis, it works better than elastography. So the sensitivity and specificity are higher than 90%, but still it would be difficult to convince especially the surgeons in multidisciplinary meetings based only on elastography and contrast if the final biopsy is negative. So we still do all of them in a row in the same examination. It doesn't take too much time, so you can do both elastography and contrast enhancement. It takes only 2 minutes, and then we do a final biopsy. If you look at 3D examinations, there are some advantages of 3D reconstructions. So you can locate the tumor, you can better see the relationship with the neighboring vessels. So this might lead, there are claims in the literature that it might lead to improved staging or resectability if we have a volumetric examination of the tumor like this image here. So basically what we would like to have during endoscopic ultrasound, we would like to have comparable images with CT and MR, and we would like to have maybe reproducible images if we have volumetric examinations like this one. So this works, this is an example on how it works on transabdominal ultrasound, but it's done in the same fashion during endoscopic ultrasound. So basically the transducer is rotated. So if you use a linear transducer, you have to rotate it, and then you catch various sections of the tumor and the surrounding vessels, and then you do the reconstructions. And these are some images from a friend, from Michael Hocke in Germany, and you can see the tumor and also the surrounding vasculature. The advantage of this kind of 3D reconstructions, for example, this one, we have used a bit of contrast and we have used also power Doppler, and you see the volumetric reconstruction. So the tumor is hypo-enhanced, so there are only limited signals inside a tumor, but you see very nicely the collateral circulation and also the splenomesentery confluence. And after you have this volumetric information, what you can actually do is you can do various sections through the tumor, so you can delineate better the planes, the 3D planes, and you can see the relationship in between the hypoechoic tumor and the splenomesentery confluence here. So you can maybe better appreciate the encasement of the tumor. This is another example. So you see the tumor here, hypoechoic tumor on 2D imaging, and you see the 3D reconstruction. So this was the celiac trunk with the splenic and hepatic artery, and you see the relationship of the tumor with the celiac trunk. So of course the doctors are doing this when examining in 2D, so they have their own reasoning behind the reconstructions, but it would be nice if we would have automatic reconstructions. We would wish to have something like this also in elastography. This is done with the transabdominal probe, a volumetric probe. Whether or not it's helpful, nobody knows. So it's like technology in search of a disease, but you can transform this information into palpation technique. So maybe it would be nice for the surgeons to palpate the tumors before the surgery and not during the surgery. So in terms of staging, there are only a few meta-analyses in the literature. So looking at the tumor staging and vascular invasion, so this is one of the meta-analyses. So actually for T1, T2 stage of pancreatic adenocarcinoma, the accuracy is around 90%. This is also valid for T3, T4 stage, and it's less for end staging. And this is because with US, we cannot really appreciate if a lymph node is benign or malignant. You have to do FNA or FNB for that. And the accuracy is slightly higher. It approaches almost 95% for vascular invasion. So the advantage of endoscopic ultrasound, especially when using contrast, is the resolution. The resolution is usually better than CT and MR, and this is an example of a pancreatic adenocarcinoma invading actually the celiac trunk. So it was complete encasement. So you see tumor tissue here, which is hypo enhanced, and tumor tissue most probably here. So this was complete encasement of the celiac trunk. You see the splenic artery, not much of the hepatic artery, and this high resolution might be useful for the examinations. So you can, if you have information also on CT, you can look at the portal vein invasion, and this is an example, invasion of the tumor of the common bile duct and also of the portal vein. You can look at the splenic vein invasion. This was an example of invasion, direct tumoral invasion of the splenic vein. And you can see also pancreatic collaterals in a lot of cases, and this is a sign that the vessels are involved, usually the either the splenic or the portal vein or the splenomesenteric confluence when you see collaterals like this one. So it's an indirect sign of invasion. Sometimes during US examinations you see small liver metastases or ascites, so even if they are not reported on CT or MR, the resolution of US is very good, and you can actually target those small lesions and get a diagnosis. You can also use contrast enhancement if the grayscale image is not perfect. You can use contrast enhancement for targeting, and this is an example. So you see that the left liver lobe was inhomogeneous, but if you look with contrast enhancement, you immediately see the hypo-enhanced liver metastasis. So you have to go further than the arterial phase towards the portal and the late phase, and you can actually puncture the lesions in real time under contrast enhancement guidance. So what is the future? We will probably need better techniques. We will need probably fusion imaging. This is an example from a friend in Verona, from Professor Mirko Donofrio. This is transabdominal ultrasound with fusion imaging. So it's a pancreatic ductal adenocarcinoma, which you can see on transabdominal ultrasound, but also on CT. And you can actually guide your therapy or radiofrequency ablation based on both images, ultrasound and also CT. We might need augmented reality. So this is good. It's used by the surgeons. It's interesting for preoperative planning, and you need 3D rendering and this kind of reconstructions with visualization of the tumor. So it's available for CT, but we would like it to have it also with ultrasound in a fusion image. We will need probably better versions of 3D. So this is an example of recent software. So it's a combination of Olympus plus Canon. So it's a large cystic mass. So whenever you do 3D reconstructions, you have to do a swap through the cystic lesion, and you can see here how the 3D reconstructions look like. So you can actually look inside a cyst. What we will need probably in the future, we will need better transducers, and cardiologists do have it. So this is an example for transesophageal echocardiography. So it's a 4D transducers, which is really small, so it can be embedded into an EUS transducer. And you see they have very nice 4D images. So that is what we will probably need also in gastroenterology. And we will probably need a lot of artificial intelligence, because this will help a lot the diagnosis. So in green is the normal pancreas here, and you see a small tumor here, how it looks like. But it will also help staging. So basically, when looking at staging purposes, if you look at this convolutional neural network, which does detection of the tumor here, it's a neuroendocrine tumor and the pancreatic parenchyma here, and you also see the vessels very nicely. So you can actually get a better let's say delineation of the vessels, and you can also see it here. So it's a neuroendocrine tumor which was hyper-enhanced with some spaces, necrotic spaces here, and the pancreatic parenchyma here, and the vessel here. So you can better appreciate the let's say the relationship in between the tumor and the vessels if you have this kind of segmentation techniques. So thank you very much.
Thank you very much for a wonderful lecture, Dr. Adrian. Yeah,
A
go
great
ahead.
talk, Prof, as always, and great admirer of your presentation. My question is regarding pancreatic adenocarcinoma. They have severe desmoplastic reaction. So, are there ways to predict sonographically on B mode or elastography or something on a strain ratio so that we can avoid those areas? Because elastography only say benign or malignant, two spectrum, right? So, any tips to avoid those areas?
Yeah, it's an interesting question. So there are studies on using either elastography or contrast enhancement for targeting of the fine needle biopsies. I think that the results are still a bit controversial. So the studies didn't show better results with US guided FNB when using elastography or contrast for guidance. What we do, I mean, if you have a very large tumor with necrotic areas, we usually do contrast. If you have necrotic areas and you don't see any vessels, we prefer to target the areas where there are still a few vessels, so the viable portions of the tumor. But you need some sort of perfusion imaging, so you need contrast enhancement. I don't think elastography will help there too much, and Doppler or power Doppler, they don't help too much. So you need contrast enhancement because you need to see the small vessels actually, which are visible with contrast enhancement.
Small, I think what I personally doing, I usually target that area where the vessel is involved. Maybe closer to the vascular invasion. Could that be helpful? Yeah.
I think everybody does it in a different fashion. We usually do fanning for diagnosis,
definitely.
but of course we try to target areas. You can easily target a thrombus if you see one in the portal vein or in the splenic vein. That's not a problem, especially with FNA needles. With FNB, you can still use it. I mean, I don't see a problem with that.
Or I like to target right where bile duct becomes obstructed.
Yeah.
That's a good spot.
I agree. Yeah, I agree.
Great talk, Adrian, as always. I wanted to ask you about your practice with regards resectable PDAC of the body and tail. Given the 0.3% seeding rate, which is now kind of well established, are your surgeons happy to go ahead without tissue, or what's your comment about that?
We usually do FNB, so
just accepting that number.
I mean the seeding rate, I think it's really low. It's the same discussion in cholangiocarcinomas, in Klatskin tumors. So there are centers which prefer to avoid FNB, at least in our center, and we have quite a large oncology department. So they always want the diagnosis before multidisciplinary meeting and before deciding on surgery. So we still do puncture from the body, tumors in the body and tail of the pancreas.
Thank you. Thank you.
All right. I think, thank you so much, Dr. Adrian.
Thank you very much.
Excellent lecture.
So the next talk will be from Prof. Seo Dongmong, and he is an early flight to catch. So we have a video presentation, and it's been honor for me to introduce Prof. Seo. He's the director of WISE and a professor of medicine from Asan Medical Center, which is one of the center of excellence in Asia, and also the lead in the pancreaticobiliary in WEO and the director of WISE International School of US, and the pioneer of RFA as well. So his talk will be on RFA and organ preserving strategies. Yes.
Thank you, Chairman. It is my real pleasure to join this joint meeting between ASGE and the Pakistan Gastroenterology and the Liver Disease Society. The title assigned to me is US RFA Techniques and Organ Preservation Strategies. This is my disclosure slide. I'm consultant to StarMed Company, which is one of Korean company producing RFA devices. These are the areas I'm going to cover during my talk. Let me begin with the basic principles of RFA. RFA is local ablation modality by delivering energy to target area. It is composed of RF electrode, down left side figure, and RF generator, down right side figure. RF generator supplies RF power and produce voltage difference between active electrode and reference electrode. RF electrical field oscillate with RF frequency and causes oscillatory movement of ions in the tissue. This movement will create frictional heat, and tissue heating is the main mechanism of RF ablation. Percutaneous RFA has been used in clinical practice for a long period of time and mainly done by interventional radiologists. On the other hand, EUS-guided RFA is relatively new field. This schematic video shows how we can do EUS-guided RFA for pancreatic tumor. After insertion of echo endoscope, we can delineate the pancreatic lesion on the EUS, and then we can use RFA electrode to puncture the lesion, firstly to the deeper part, and create ablation by applying RF power, and then retract the needle into the superficial part. After one line ablation, we can change into the different direction and create another area of ablation. By repeating this maneuver in several different planes, we can create whole tumor ablation. Let me show you how this technique can be applied for benign solid tumor ablation. This is 49-year-old male patient admitted because of recurrent hypoglycemic attack. CT shows enhancing nodule and EUS shows hypoechoic elliptoid nodule. When you apply the contrast-enhanced EUS, it shows very strong enhancement during arterial phase, which is consistent with neuroendocrine tumor, including insulinoma. After discussion with the patient, we decided to do EUS-guided RFA instead of surgery. But the lesion was very close to main pancreatic duct. To protect MPD, we inserted ERPD stent first. This is EUS view at the time of RFA. After insertion of 19-gauge electrode, we applied RF power. Now we can see echogenic cloud formation near the active electrode part. It is 1 cm electrode. After one site ablation, we changed the needle direction to non-ablated area and created another ablation. If you want to see the real ablating zone, if you apply E-flow image, it is quite helpful. After RFA, the patient's blood glucose level increased dramatically, and insulin and C-peptide dropped down. The patient became symptom-free. This CT follow-up shows complete disappearance of insulinoma. Our early study of EUS-guided RFA for benign solid pancreatic tumor enrolled 10 patients, NET, SPN, and insulinoma cases. Among them, 70% of the patients showed complete resolution, and the complications were minor abdominal pain or pancreatitis. We reported this result in endoscopy 2018, and our conclusion was EUS-guided RFA may be safe and potentially effective treatment option in selected patients with benign solid pancreatic tumors such as insulinoma, SPN, or neuroendocrine tumor. Let me move on to EUS RFA of pancreatic cystic tumors. Indication first. At the current moment, we cannot say definitive indication because there are not many studies and published data specifically focused on cystic tumor ablation. But if we say our included cases during our study, the honeycomb-shaped serous cystadenoma and the cystic tumor showing solid areas are included. Unilocular or oligolocular cysts, in our group, we are using ethanol lavage and retention therapy actively, so we don't feel RFA is necessary on this case. And IPMN, there can be some controversies. We need to do more study. Many people think serous cystadenoma doesn't require any therapy or any follow-up, but my thought is different. If you see this case, left side CT scan shows a small cystic lesion in the body of the pancreas, but 6 years later it became large and causes compressive effect to the pancreas. If we focus on pancreas body and tail of this patient, during 6-year period, it underwent marked atrophic changes. It is long-term complication due to mass effect. To prevent this, I think it's better to do something, although it is not malignant lesions. This is one example case. We used RFA to palliate the mass effect of serous cystadenoma. Left side showed medium-sized cystic tumor in the pancreas body, but 4 years later, the cyst became large and replaced body of the pancreas parenchyma. Upon EUS, it showed the central stellate scar and also multiple divided locules. So we did EUS-guided cystic fluid aspiration first to make the septum more crowded before RFA. This is EUS video at the time of RFA. After cystic fluid aspiration, the cystic tumor became a little smaller and the septum became more crowded. Our target was crowded septum, and for this we used a 19-gauge electrode, and the active part was 1 cm. And we used 50 watts power since this is a pretty large cystic tumor. If the tumor is small, then we can modify the power into 30 watts or 20 watts. The bottom is already ablated. Now we are targeting superficial part. After insertion of electrode, we are applying RF power. Now we can see echogenic cloud formation around the active electrode, meaning that this area is ablated. But this is just one plane ablation. After one plane ablation, we need to torque our echo endoscope and try to find out non-ablated area. And for this area, we use the line ablation, which is meaning after deep insertion of electrodes, while directing the electrode little by little, we apply the 50 watts power continuously to cover a long area of the cystic tumor. If we do point by point ablation, it takes too much time. After this plane ablation, we try to find out another non-ablated area until the completion of RFA. Left side CT is before treatment. On the right side, 6 months after, we can see marked volume decrease of this serous cystic tumor. During this study period, we enrolled 13 patients with microcystic serous cystadenoma. And the median size of the tumor was 5 cm. And presenting symptoms were abdominal pain or discomfort in 10 patients, and MPD dilation observed in 3 patients. If you look at the treatment response, complete resolution was 0%. It was not our intention. But partial response was observed in 61% of the patients, stable disease in about 38% of the patients. But there was no serious complication. So our conclusion was, when we target microcystic serous cystadenoma by EUS-guided RFA, about 60% showed partial response, and it was technically feasible and showed an acceptable rate of adverse event. However, whenever we do RFA, we always need to be very careful not to cause serious complications. This is MEN1 patient, a 38-year-old female patient. She had insulinoma and received US-guided ethanol injection 3 times, 2011, 17, and 21. Now we can see recurrent tumor in the head and the tail area. For the ablation of 2 cm head lesion, we used 30 watts and 6 line ablation with continuous mode. 1.6 cm tail lesion was ablated using 30 watts and 4 line ablations. After ablation, the patient developed low-grade fever and abdominal pain. So we checked CT follow-up 5 days later. The head area shows retroduodenal perforation here, and the tail lesion showed large necrosis. But we did a conservative care, and 8 days later CT shows the head perforation seems to be closing, and the tail lesion necrotic area is becoming small. But this patient developed bleeding and hematemesis. When we did endoscopy, the bleeding is coming from ampulla bata, so we did ERCP. When we tried pancreatic duct cannulation, the guide wire easily go to the necrotic area. Quite difficult to find our normal P duct, but we were able to insert pancreatic stent, then try to insert guide wire into the CBD, but the guide wire course was from MPD, necrotic cavity, and CBD. So there was biliary and the pancreatic fistula. To cover this fistula, after insertion of ERPD, we inserted fully covered metal stent into the CBD, and the patient was discharged. Recent meta-analysis of US-guided RFA shows clinical success rate of 85% and a technical success rate of 94%. Adverse event rate was 14%. Among them, pancreatitis rate was 7.8%, but serious necrotizing pancreatitis were rarely seen. Let me move on the long-term effect of organ preservation. This is US-guided cyst ablation data, not RFA data, but we can see what is the long-term effect of pancreatic resection. We compared 310 patients of US-guided ethanol ablation group and 310 patients of surgical resection group. Both are propensity score matched, so similar group. When we look at the cumulative long-term morbidity, compared to US-guided treatment, surgical treatment had a lot of complications. Immediately after surgery, the complication rate ranges from 20 to 30%, but even after 5 or 10 years, we can see a continuous increase of the complication. During this late period, there are various types of complications. The pancreatic jejunostomy sites and the choledochore jejunostomy site are quite vulnerable, so obstructive pancreatitis or cholangitis, bile duct stone formation, and finally secondary biliary cirrhosis or varix formation are all possible complications. Pancreatic parenchyma also undergoes atrophic changes. Left side is immediately after PPPD. We can appreciate pretty large amount of pancreatic tissue, but 18 years later, we cannot see pancreatic parenchyma at all, only dilated pancreatic duct. This is long-term complication after surgery, but this is definitely underreported. If possible, it's better to avoid this kind of complication. If you develop local treatment modality, then it would be very helpful to avoid this kind of complications. In conclusion, US-guided RFA can be applied for benign solid tumors and cystic tumors and even for pancreatic cancer. But many areas are still investigational and we need more data. but it can preserve pancreatic function and can give better quality of life in the long run. Thank you very much for your kind attention.
So we thank Dr. Dongwan Seo for his really nice and authoritative talk. In the interest of time, we will not take any questions on his behalf. We will move on now to the last talk of the session, and this is the only talk without a EUS focus. This is by Dr. Amol Bapai, who is not able to give his talk in person, so this is done by video. Dr. Bapai is chief of his hospital Department of Gastroenterology in Pune, India. He is multi-talented and in the whole range of therapeutic endoscopy from EUS all the way to third space, and including ERCP, of course, and resection techniques. So his talk is going to be entitled Oncology, Third Space Endoscopy, and New Horizons. We'll now play his video. Thank you, Usma.
Good afternoon, and thanks for the kind invitation. No relevant disclosures. So let us begin by understanding what is the third space. So we are all familiar with the first space, which is the luminal endoscopy, and the second space is the intraperitoneal space, which is exploited by surgeons as well as endoscopists who perform those procedures. But there is a potential space in the submucosa of the GI tract, which can be used to perform several procedures, and this is called the third space or the submucosal space that is utilized for endoscopic procedures. And how did all this begin? So mucosal surgery started with polypectomy for pedunculated polyps and went on to endoscopic mucosal resection and endoscopic submucosal dissection for flat lesions and belly cancers, and then full thickness resection for other specific lesions. And this, in combination with developments in nodes, helped us to have an improved knowledge about the submucosal space. And this led to an explosion of third space endoscopic procedures, which are also called submucosal operations. The index procedure being the POEM procedure, but in the context of our oncology, we need to look at ESD, full thickness resections, and stir and poetry. This is what we're going to be focusing on in this talk. So, third space endoscopy or GI endosurgery, we have to understand that it is the byproduct of advances in imaging and diagnosis, evolving concepts of disease management, and advances in technology, particularly endosurgical techniques and closure techniques. And this is the gut wall with the submucosa in between, and we have the mucosa on the luminal side and the muscularis propria on the mediastinal or the peritoneal side. And when we try and target one side of the submucosas, for example, if we try and target on the mucosal aspect, then we have to treat, we can have the ability to treat mucosal diseases, and vice versa. When we tackle the muscularis layer, we have the ability to treat deeper lesions. So let's look at the mucosal lesions first, and the first development and advance in endoscopic imaging is basically this, that we have this ability to detect early cancers and even microscopic cancers in the last 7 decades of endoscopic evolution from the 1950s to 2020s, and also the development of endoscopic ultrasound, which helps us to visualize the wall layers of the GI tract and also predict invasion into the deeper layer. So based on that, basically the philosophy of endoscopic resection for early GI cancer, based on the fact that depth of tumor invasion increases the risk of lymph node metastasis as the tumor burrows deeper into the submucosa. And it is the SM2 layer which is the watershed area, because that contains the lymphovascular plexus. And so until the tumor is limited to the mucosal layer, the risk is under 3%. But once submucosal invasion occurs, the risk of lymph node metastasis goes up to 18 to 20%. And in order to detect this, we need to be able to resect the tumor in its entirety along the deep margin as well as the lateral margin, so that we get an en bloc resection, so that we can prevent residual or recurrent disease. And based on that, there are predominantly two techniques which deal with mucosal lesions and mucosal malignant cancers and pre-malignant lesions, EMR as well as ESD. And we are going to be focusing on mainly ESD because the plane of dissection is in the SM3 layer, and it gives us the potential ability to be curative, and it follows oncological principles as compared to EMR, which often does not adhere to oncological principles. So ESD has become and been the mainstay of treatment for early cancers in the stomach as well as in the colorectum, particularly high-grade dysplastic lesions in the colorectum, as well as in other areas like the duodenum. And these have become, standard of care procedures now in GI endoscopy in the last couple of decades. So much so that today we have very standard guidelines which lesions should go for an ESD as compared to lesions which can be treated by EMR. So that's very clear. And as an extension to ESD, we can also perform intravascular dissection in select lesions in, like, for example, in T2 rectal lesions without lymph node metastasis. And particularly, these are distal rectal cancers where the alternative is surgery with a permanent stoma. So with an intramuscular dissection, we can get the en bloc tumor out, and this is often combined with adjuvant chemoradiation, and that is shown to give very excellent result. And now let's get to the deeper layers. And when we look at the muscularis propria layer, we have to understand that majority of the lesions in this layer are subepithelial lesions characterized by, these are some of the lesions, but the commonest ones being the GIST tumors and leiomyomas and some neuroendocrine. All these tumors have particular peculiarities, and they're all well circumscribed and encapsulated, and the capsule needs to be preserved during resection. The tumor biology in these lesions is different as compared to mucosal tumors, which are more invasive. Subepithelial lesions have a low risk generally for lymph node metastasis and distant spread, and therefore radical surgery is not recommended and organ preservation is the rule. Many of these lesions can be enucleated, and we of course need to look for multi-lobe extensions to prevent recurrence. So when we try and diagnosis of these lesions involves endoscopy as well as endoscopic ultrasound, because we need to characterize these lesions, differentiate between a GIST and a leiomyoma, sometimes along with biopsies, which can be EOS guided or incision biopsies. One caveat though, that tumors less than 2 centimeters, the yield of biopsy is pretty low, but for larger lesions, biopsy is definitely mandatory. And then resection of these tumors, which earlier used to be laparoscopic, is now more and more often being performed endoscopically. So let's see how these procedures can be performed. So when we plan these resections, we need to understand whether the tumor is endophytic or exophytic. For endophytic tumors, only resection is adequate, whereas exophytic lesions will require resection followed by closure of the defect. Otherwise, if the defect is open, it can lead to a full thickness perforation. So based on that, we have EFTR, which can be non-exposed using a device, or it can be exposed, which can either be a straight exposed or a tunneled procedure, and we will see basically these two procedures. So whenever we perform full thickness resection, we need to close the defect, and that is what is important. So if the defect is small, you can use standard clips, but if it's a wide defect, only TTS clips don't work very well, and then we need to use a combination of endoloop and clips. So here you can see that this is a large defect. We place an endoloop and we fix it to the edges of the defect, and then we can tighten the loop to create a bursting kind of a suture. And this is very effective, and it gives a very secure closure. And for the selected indication, so if the defect is small, success rates with just clips is above 90%. But if for larger defects, we need to use the loop and a clip technique, which gives us better yield. Of course, we have full thickness clips as well. So over the scope clips or the full thickness clips, which have a much more robust closure because they are larger clips, and we all know that they go over the tip of the scope and they can be fired using a tripwire mechanism. And using a combination of suction and graspers and everything, So we can have a very secure closure for defects up to 2 to 3 centimeters. That is very effective. And for the correct defect size, the closure is very effective using these techniques. Another option is to use an omental patch to close these defects, very similar to what surgeons use in surgical techniques. And of course, we have the overstitch, which is really revolutionized the way we perform this procedure, because here you can suture the entire defect and a full thickness suturing can be performed. And some of the challenges with the overstitch is that it requires a double channel endoscope, it requires a learning curve and technical expertise, and it's also a very expensive device. But the advantage is that any lesion and any defect can be closed. Now with the X-Tack and the Overstitch NXT, the newer generation devices, we can use them over using a single channel scope as well, and that gives definitely good results. So apart from the cost, the closure with the endoscopic suturing is probably the best, no doubt about that. So that brings us to the tunneling approach and the stir procedure, which is a principle derived from POEM. And here what we do is, instead of opening the mucosa and the muscle layer at the same point, we create a tunnel in the submucosa so that the mucosa and the muscle layer are breached at different points. This improves the safety of the procedure and enhances the safety because of this mucosal flap valve. The challenge is the tumors up to 3 to 4 centimeters can be resected very easily, but as the size of the tumor increases, very often things can become difficult and the procedure becomes more challenging. But in general, we can see that the results of STIR are excellent, with excellent en bloc resection rates and minimal and acceptable adverse events. Some new concepts that have been evolved in the last few years. We need to choose between EFTR and STIR, and we have to discuss about morcellation and also some other technique. So depending on the location of the lesion in the upper GI tract, we may have to choose between STIR and EFTR based on this picture over here. There are some areas which are more suitable for STIR as compared to others which are more suitable for EFTR. Very large tumors, and how do we access them? Because as I mentioned, large tumors can become difficult to treat by STIR because it is impossible to deliver them out of the mucosal opening. So what we can do is we actually perform an intracorporeal morcellation. So we cut the tumor into multiple pieces and then deliver the tumor pieces out of the mucosal incision and mouth before closing the defect, and this is how we can get that. And particularly if there is a mucosal infiltration by the tumor, then we need to perform an EFTR as compared to a STIR that can be performed if the mucosa is free. So these are two lesions at the inner rectal junction, and we can see that in one case, because there is no mucosal infiltration, we are performing a STIR, whereas on the other side, we're performing a full thickness resection, and that's how it is. And this is particularly true for, all these techniques are true for endophytic lesions, but for exophytic lesions which are growing on the serosal aspect, we can actually perform a subserosal dissection also. And this is a video that has been presented at the World Cup of Endoscopy this year, that after treating these patients with imatinib and reducing the size of the tumor, we perform a tunneling. We go out through the tunnel and into the peritoneal cavity and approach this tumor from the peritoneal aspect. This is the tumor that you can see, and because of this, it gives us precise control of the dissection as well as precise control of hemostasis, and that is the advantage over a standard full thickness resection that we may do from the interluminal side. There are techniques in laparoscopy where endoscopy and laparoscopy can be combined for resection as well as closure of these defects, and several techniques have been described, as you can see over here. And the last point that I would like to touch upon is patients with complete esophageal obstruction following radiotherapy can be treated by recanalization of the lumen using this special technique called as a poetry or peronal endoscopic tunneling restoration of the esophagus, wherein we create tunnels on the antegrade and retrograde side and meet in the middle, and we pass a guide wire from one side to another, place a fully covered stent, which is left in place for 4 to 6 weeks, and this leads to a new esophagus formation and new recanalization, which just needs to be dilated intermittently, and the patient has the ability to eat like this. So this is a very impressive technique which has been described. Therefore, to summarize, third space endoscopy in oncology, we need to understand the submucosal layer anatomy in detail, because that helps us to plan the treatment strategy and to select the suitable procedure. ESD, as we all know, provides an en bloc resection for mucosal cancers and pre-malignant lesions, whereas EFTR and STIR have shown excellent modalities for treatment of subepithelial lesions from the MP layers. Third space endoscopy in general offers an improved safety, efficacy, and outcomes for suitably selected GI tumors, and novel approaches which combine various modalities like endoscopy and surgery, endoscopy and chemotherapy. This helps to improve the outreach and outcomes of endoscopic resections in these situations. Particularly, poetry is a novel technique which can help to restore continuity of the complete esophageal obstruction in otherwise these miserable patients. A warm welcome and invitation for those who would wish to join us either in person or online for our meeting in August in India. And thank you so much for the opportunity.
So we thank Dr. Bapai very much for his video presentation. That actually brings us to the close of this session, and I really thank all of you diehards out there for staying with us all the way to the end. I think we can take a couple of questions.
If you have
Shall
any.
we?
I thought it was a very interesting session.
Yeah,
Obviously,
it was.
endoscopy is pushing the envelope in the field of oncology more and more, and I think it's a really exciting time for patients. And it does make for more interesting conversations during the tumor boards. Maybe not as much as with Dr. Sharma, but because we're not doing EUS routinely for lung cancer, which brought up a point. I didn't want to say it to him because I got nervous. Unless they do EBUS and there's some other node, in the posterior mediastinum that they feel on imaging needs to be sampled, then they'll send it to us. But we're not for lung cancer doing it routinely.
Yeah, no, that's the same for us. And is that the same for you?
Yeah,
And, what about you, Adil?
Yeah, pulmonary guys, they're not happy because I'm doing the mediastinal cases for them.
Oh,
Yeah,
interesting.
so the endoscopy is evolving starting 50 years ago from diagnostic ERCP, and now is going towards, there is no boundaries now. So now treatment with the cancer patients. So
yeah, I think we should be working together. I mean, it's perhaps not so much about who does the procedure, but whether the patient gets the best care. And we're happy, I think, to share all this with each other. But actually, it was this brings up when you mentioned tumor boards, this brings up an interesting aspect of it, because I find that our surgeons perhaps may not very often the tumor boards are directed by surgeons and oncologists, and they may not be quite aware of the whole spectrum of services that we can offer oncology patients. So maybe we need to be maybe more active participants in some of these tumor boards.
No, that's what either myself or one or two of my partners, we always try to make tumor board. Of course, it's Tuesday at noon in the middle of our endoscopy schedule, which is the worst time.
Or clinic.
Maybe a collaboration with these surgical societies, some talks over there.
Sometimes we do, but tumor board, I feel like anytime there's an opportunity, we'll chime in and say, we can actually target that lesion, and we bring up the RFA. But as I was saying on that front, my surgeons are not as excited about RFA in the pancreas. They're still worried about pancreatitis based on older data and older devices. And I do have a surgeon for neuroendocrine that likes to enucleate, but I guess it also highlights the variances in practice. at different centers, different countries, which again makes it more important we show up to tumor board, which I
Yeah.
wasn't doing when I first started at U Chicago as much, to be honest. And I realized we were missing out and not updating our colleagues on what we can do. So
Yeah, no, I absolutely agree. I think I personally need to make more of an
Yeah.
effort to show up at tumor boards, and these are all done on Zoom these days.
Yeah.
So
we switched
yeah,
to
it
Zoom
makes it a
now
lot
too.
easier.
So, yeah.
Any comments, questions from the audience? I beg your pardon? Thank you for staying too. Thank you.
I think in the end, I want to thank all my co-moderators, Prof. Usma, Prof. Nantali, and my boss, Dr. Chris, all the speakers, and for the topic endoscopic oncology, something to look forward. We all support in future. Yeah. Thank you, everyone.
Thank you very much.
Thank
Thank
you.
you. Thank you.